Thank you, Dr. Warner. Can everybody hear me? Okay. I'm an interventional radiologist in private practice in Denver, Colorado. I'd like to thank Bob and Marianne, as well as Dr. Woltering, for inviting me to speak today. I'll try and catch up a little bit on time. I've been asked to speak on liver-directed therapies, specifically radioembolization versus chemoembolization versus bland embolization, which one of these is best. And Dr. Woltering might be upset with my concluding slide. When I see patients, I'm looking at whether these patients are reasonable for a localized therapy or a regional therapy. The patient on the left side of the screen has a single tumor in the backside of the right lobe of the liver. That's much more of a patient who would benefit from a local therapy, whereas patients who have diffuse disease spread throughout both sides of the liver would benefit more from a catheter-directed or regional therapy. The barriers to liver resection: if you're going for a cure, only about 10 to 15% of patients are able to undergo a surgery. And that's because tumors can be widespread throughout both sides of the liver, or they may not be able to undergo the rigors of a surgery. Now, that's different if you're just trying to debulk the patient, and more patients can be treated that way. When we look at regional liver therapy, we're talking about putting a catheter in, usually from the groin or the wrist, into the liver. It's a small catheter about the size of spaghetti, going into the area that are supplying the tumors and delivering an embolic agent. Embolization just means that we're getting something to stick either in an artery or a vein. We use very sophisticated guidance systems right now to deliver these therapies. Once you get the catheter in the position, you can then either deliver bland particles, which can be polyvinyl alcohol or trisacryl gel, different materials that will block off the arteries. You can combine those with chemotherapeutic agents, which will allow the chemotherapy to dwell or sit in the region of the tumor over a longer period of time. There's also radioactive materials like yttrium-90 that you've heard about that we can infuse. We know that cytoreduction can improve symptoms and overall survival in these patients. So whether that's a surgery, an ablation, or a regional liver therapy. What's unique about the hepatic artery? Well, the liver has a dual blood supply. It gets about 80 to 90% of its blood from the portal vein, which is deoxygenated blood that drains from the gut back up into the liver. It also has another blood supply, which is the hepatic artery. The tumors are relatively smart, and they know that they need oxygenated blood with nutrients that come from the artery. So even though a large part of the blood supply to the liver comes from the vein, the tumors derive up to 80 to 90% of their blood from the hepatic artery. Tumors, by their nature, secrete hormones and proteins that increase the blood supply to these tumors. So when we do cross-sectional imaging or pathology of the tumors, there's anywhere from 3 times to 20 times more blood supply going to a tumor than the normal liver just adjacent to it. This is an animation, and what it's showing is the blue blood is the portal vein, the red blood is the hepatic artery. The tumors are deriving their blood supply from the hepatic artery. We put the small catheter in from the groin. We direct it up into the liver, and specifically the area supplying the tumors, where we slowly release these particles. Now, these can be radioembolization particles, bland or chemotherapy particles. They travel downstream where they get lodged at the periphery of the tumor, where they exert their localized effect. How much of the liver do we treat? In most patients that are coming to see me, unfortunately, they have disease spread throughout both sides of the liver. If it were a solitary tumor on one side of the liver, I'd put the catheter up into that area and just treat that tumor. If it's disease including both sides of the liver, then we would treat both sides of the liver. If we're using chemoembolization or bland embolization, we tend to treat the most diseased portion of the liver first, and then 30 days later, bring the patient back and treat the other side. So it's usually a right-sided treatment followed by a left-sided treatment 30 days later. Who's a candidate for this therapy? Patients who have liver-dominant or liver-only disease. You need to have a pretty good performance status on day-to-day living activities, and the liver function studies have to be pretty normal. The most important predictor of hepatic reserve is the total bilirubin level. And usually in patients with neuroendocrine disease, we'll treat the livers up to a bilirubin of about 1.8 to 2.0. If it's higher than that, we don't treat the patients because there's a fear of liver failure. Dr. Liu spoke this morning about a multidisciplinary team. I think this is the only way to go, especially with a fairly rare complex disease. You need to have everybody on your team. You need a good quarterback, and that's imperative. I'm not the quarterback. I'm the guy that they pull in if there's liver disease, and I communicate with everybody on the team, but it's important to know your place in this algorithm. Bland embolization. This is where we put the catheter in the liver and the tumor, and we inject particles. These particles travel downstream. The arterial tree is similar to a regular tree in nature, and things get smaller as they go out into the periphery. When we deliver these beads, they travel downstream until they become lodged at the smallest point in that arterial tree, which is typically at the periphery of the tumor. Chemoembolization is mixing a chemotherapeutic agent along with an embolization product. And the idea is that when you inject this material, it's going to travel downstream, get stuck in the tumors, but because you've blocked off the blood supply, it's not going to wash out quite as easily. So there's increased dwell time where the chemotherapy is in proximity of the tumor. There are lots of different papers. There's actually 25 to 30 papers looking at embolization with chemoembolization and transarterial embolization, which is just the bland product. Many of these papers commingle those cohorts of patients. They're very difficult to tease out who does how well. There's different chemotherapeutic regimens in the chemoembolization papers. There's heterogeneous patient population, and there has never been a head-to-head study looking at chemoembolization, radioembolization, and bland embolization. This is one study early on, 2003, from MD Anderson, looking at 81 patients. There were only 9% of patients who actually demonstrated progressive disease in this patient cohort when they were treated with either bland embolization or chemoembolization. This is a recent paper that came out of Pittsburgh within the last year or so, and it was 15-year follow-up. So by far, it's the longest follow-up on neuroendocrine cancer patients. The average treatment, they received about 7 treatments or 7 chemoembolizations. You can see the response rates there, the overall survival at 3, 5, and 10 years. And they felt that chemoembolization was a reasonable therapy to decrease symptoms and help prolong life in these patients. Drug-eluting beads. This is the evolution of chemoembolization. Beads that actually soak in chemotherapy that we can then deliver to the patient, and they exert very localized effects. The problems with chemotherapy in general is there's systemic toxicities associated with them. That's fine if you're giving a systemic agent, but if you really want to localize it to the liver, you'd like to get rid of some of those toxicities. Drug-eluting beads are a way to give very high doses of chemotherapy to the liver with very low systemic toxicities. There were 2 recent papers published looking at drug-eluting beads treating patients with neuroendocrine cancer. It looks like it works. Unfortunately, there were some biliary problems, some problems with the bile duct that were probably directly related to the drug-eluting beads. So we do not include drug-eluting beads in our typical regimen of regional therapy to the liver. The time course of toxic events. I wouldn't say these are necessarily toxicities, but we do see patients who early on, if we're going to use chemoembolization, drug-eluting beads, or bland embolization, they tend to be treated as an inpatient because we know within that first day or 2 they're going to have pretty significant pain in the belly. That's post-embolization syndrome, low-grade fever, and some nausea. Those issues are easily controlled with IV medication, but they're definitely harder to control at home. Then there's a delayed onset of fatigue, and that usually lasts for about a week or 2. Whereas if we look at radioembolization, patients tend to feel pretty good for the first 3 to 4 days. Then they start getting fatigue, and that slowly clears up over about 7 to 10 day time period. If you look at patients with pancreatic neuroendocrine tumors, hepatic arterial embolization versus TACE, patients with the pancreatic primary tend to do better with TACE. Whereas if you look at carcinoid patients, it really was about the same efficacy, whether it was a bland embolization or a chemoembolization. Radioembolization. This is a product called Sursphere or TheraSphere. It's been available in the United States for about 15 years. The first case of this was reported back in the late 1960s by our own Dr. Warner. Him and Dr. Simon, in I believe it was 1967, used a product from 3M, which were radioactive microspheres tagged with yttrium-90. It fell out of favor for a while in between, and then picked back up in the 90s and early 2000s. And to date, thousands of patients have been treated with this and have done very well. Tolerance. We know that the liver fails after it sees about 30 gray of radiation. And we know that from external beam data. We know that tumors die at about 100 gray. So the question is, how do you get a preferentially high dose into all these tumors with relatively low dosing to the rest of the liver? Well, we take advantage of that hypervascularity in the blood supply. These are the two products, Sursphere and TheraSphere. It's beyond the scope of this discussion, but neither of them are FDA approved. They're both off-label use for carcinoid. One is approved for hepatoma, the other is approved for colon cancer. That being said, most insurance companies will cover this. You know about the bioavailability and radiopharmaceutical issues with yttrium-90. It tends to be about a 940 keV photon. A chest X-ray is about 70 keV. So these are very, very high energy. Each bead, which a typical dose is about 30 million spheres, creates a cloud of radiation 11 millimeters around it. So as we deposit millions of beads into a tumor, it creates this cloud of radiation that will help kill the tumor. None of these therapies that we're talking about are cures. All of these can help palliate and improve survival. This does require additional angiography. This is an angiogram or a catheter placed into the left liver artery. There's a little artery down there with the red arrow that goes to the stomach. I put a small catheter in there, and then I embolize it with a coil. I block it off with the bigger coil so that when I treat the liver, none of this, this product can spill down into the gut or small bowel. We also do what's called a shunt study. I inject a small amount of radioactivity into the liver, and I want to see how much of it is going to go to the lungs. Most of it's going to get stuck in the liver. If greater than 20% goes through the liver, then it may be dangerous to treat that patient. This is acting as a surrogate for the high-dose therapy, and it just makes it a much safer procedure. This is what the delivery system looks like. Those are the beads, that little brown container. There have been several papers looking at radioembolization results. This is that we published in 2008, looking at 148 patients. The good thing about this particular paper is we had about 70-month median survival. As you would expect, these are the primary sites of the tumors. Only 5% of patients actually progressed despite our best efforts. Most patients developed some amount of fatigue. It was rare to have any ascites or pain associated with it. You have to know that when you get your liver treated with any of these therapies, there's going to be a flare phenomenon. So if you're going to draw a chromogranin A or tumor marker specific to your tumor type, it's going to be elevated 2 weeks after the procedure. It'll probably stay elevated 4 weeks after the procedure and then start to drop off to baseline. Imaging studies at a month are going to look worse than they do before you got treated. There's edema and swelling that occurs. So we learned early on that we need to wait about 3 months before we do follow-up imaging if there's no complications with the procedure. We also found that tumor markers are very representative of what's going on in an X-ray study or an imaging study. I had a patient ask me this the other day in clinic, how did the tumors die? This is a patient that was treated. There's a tumor on the backside of the right lobe that is white on the CT scan. That's 3 months after treatment. It's created a hole in the liver. The liver will never look normal. It'll create holes where the tumor was. This patient went on to transplantation. The tumor's on the backside of the right lobe, that big circular white area. This was sectioned. All these little dots are beads or radioactive microspheres that are deposited within the tumor. This is a high magnification view, and it demonstrates coagulative necrosis. So each one of those beads is going to create a cloud of radiation that then kills the tumor around it. Again, we knew that tumors only need about 100 gray to die. When we cross-sectioned this tumor, we saw that there were up to 3,000 gray surrounding most of these tumors. Not all of them, and that's why you can't say that it's a cure. This is a patient who has duodenal carcinoid. The right-sided picture, actually the left-sided picture, shows those white areas inside of the liver. Those are hypervascular tumors. They have a large blood supply. 3 months later, the picture right next to it shows that there's no enhancement of those areas. Her chromogranin A dropped from 340 to 26. Can you do radioembolization after hepatic arterial embolization? The answer is yes. The group at MD Anderson did it. Unfortunately, those patients have been exposed to lots of liver-directed therapy, and then they fail, and then they want you to try the radioactive beads. So it worked, but there was only about 14 months of survival. Most common toxicities from radioembolization, it's rare to have any real complications. Less than 5% of patients develop a stomach ulcer. Most commonly, patients just get fatigue that lasts about a week. This is a patient who did develop an ulcer in the stomach. They were treated with proton pump inhibitors, and it healed over time. REILD, radiation-induced liver disease or failure. It's rare. It's less than 1% in the general population. There was a paper out of Spain that looked at who's at higher risk for this. Was treated. Is that me? The whole liver was treated at once, or they'd received multiple lines of chemotherapy. With radioembolization, can everybody hear me? Yeah. Okay. Portal vein occlusion. This is that big blue vein. If that's blocked off, you really can't do chemoembolization or bland embolization. You can treat with radioembolization, and there are papers showing that. Increased bilirubin. I think you need to be careful with any liver-directed therapy if the bilirubin is elevated. Ascites. That's usually a sign that the liver is failing, or you could have peritoneal carcinomatosis, other reasons that you accumulate fluid. But that's something that makes us. Do you want to use that? Okay. All right. Will you tell me if you want to use it? Okay. Prior radiation therapy. This has generally been a relative contraindication in patients, and we need to do some special calculations. Greater than 70% liver replacement, that gets a little bit dangerous, but usually the bilirubin is elevated as well. Whipple procedures, or what we call a violated ampulla, is something where the bile tube drains into the small bowel. There's a muscle there that prevents reflux of stomach material up into the liver. People who have had a Whipple procedure, a biliary stent, whether it's plastic or metal, or other anastomoses, typically have been excluded from therapy with chemoembolization or bland embolization. And that's because there's a very high risk of infecting the liver after these treatments. In our practice, we collated some data. There were 36 treatments with 29 patients. 2 patients developed an infection from that versus some of the literature looking at up to a 50% infection rate with chemoembolization. There's another paper that's coming out that almost also mimics this. So I think it's much safer to treat patients who've had a Whipple procedure using radioactive microspheres than it is chemoembolization or bland embolization. These are some of the benefits. It is performed as an outpatient and well tolerated. There's a consensus guideline that says that radioembolization can be used as a substitute for bland embolization or chemoembolization. You should know, and you should talk to your interventional radiologist, because this paper says that half the time the interventional radiologist is at liberty to use whatever they want, whether that's radioactive beads, bland beads, or chemoembolization. So that's why you really need to work in a multidisciplinary setting to make sure that everybody's on board with what therapy you'd like to use. There is a study out of Germany saying that it's safe to use radioactive microspheres after PRRT. And we could talk about that more later if we'd like to. This is in contradistinction to a paper that's coming out of the East Coast, and it's Dr. Ruff and Sulin. And these patients were treated with liver-directed therapy in the United States. And once they had failed all liver-directed therapy, then they went on to PRRT, whereas it was opposite in the other study. 70% developed bone marrow dysfunction, 25% developed kidney dysfunction, and what does that say? 31% developed liver dysfunction. So the thought is, in the United States, we treat livers very aggressively, and we beat them up over time to the point where if you get PRRT after you've seen multiple lines of liver-directed therapy, you may not do as well. So there's more work that needs to be done in this area. I would also ask your interventional radiologist, what are you going to do if I have a carcinoid reaction? If they don't know, I'd probably leave. But it's important to have sandostatin available. We give everybody sandostatin prior to the intervention, and we have a bag available if we need to give it over time. So what are the short and long-term effects? With you get post-embolization syndrome pretty much with everything that we do. With drug-eluting beads, there's an increased risk of a biloma, which is damage to the bile duct. With radioembolization, you have to have a planning angiogram. However, I can usually treat the liver entirely in one setting after the preliminary angiogram. There is a question whether we develop more scarring with radioactive microspheres than with chemoembolization. And there are some reports in colon cancer patients of the spleen getting larger. Sequencing at our hospital, I have seen chemoembolization or drug-eluting beads cause scarring of the vessel to the point where I could not treat with radioembolization after that. So at our institution, we tend to use radioembolization first. If that fails, then we switch over to chemoembolization. And all these are repeatable. You can probably have radioactive microspheres up to 3 times in your lifetime. So cytoreduction can be accomplished by regional therapy. The TACE is not better than bland embolization in carcinoid patients. The data with Y90 and PRRT is very limited and needs to be studied further. And patients really should be treated in a multidisciplinary fashion. Thank you very much.